Muy buenas noches a todos, bienvenidos a una nueva sesión del Diplomado Internacional en Neurología Veterinaria. Tengan en cuenta que esta noche la conferencia va a ser en inglés, así que si quieren escucharla en español, tienen que hacer clic en el botón de interpretación y poner español. El botón de interpretación es ese que parece un mundo chiquito que está al lado de la manito, de levantar la mano. Para aquellos que la quieran escuchar en inglés, eh, podrían dejarla en original, pero lo ideal es que pongan la interpretación en inglés, así escuchan también la interpretación de lo que se diga en español. Queremos agradecer a la Asociación Argentina de Neurología Veterinaria y a la Asociación Brasileña de Neurología Veterinaria también. Esta noche tenemos gente de todas partes del mundo y tenemos la suerte de poder presentar al doctor Steven de Decker, que nos va a estar hablando sobre neurolocalización en el sistema nervioso periférico. Steven se licenció en la Universidad de Ghent, en Bélgica, en 2005. Tras su graduación realizó allí un internado rotatorio y posteriormente su doctorado sobre espondilomielopatía cervical asociada a disco en perros. Completó su residencia en neurología y neurocirugía en el Royal Veterinary College de la Universidad de Londres. Se convirtió en neurólogo colegiado en 2013. Ahora es catedrático y jefe del servicio de neurología y neurocirugía del Royal Veterinary College. Aunque le interesan todos los aspectos de la neurología veterinaria, la mayoría de sus investigaciones y publicaciones se centran en los trastornos de la columna vertebral, la neurocirugía y el racionamiento clínico. Ha publicado en diversas revistas internacionales y presentado la mayoría de sus trabajos a nivel internacional. Le gusta enseñar y por ello participa regularmente en eventos de formación continua alrededor del mundo. Bienvenido, welcome, Dr. Steven. El auditorio es suyo, así que cuando quiera pueda compartir pantalla. Una cosa, en la sesión de hoy, vamos a dejar las preguntas para el final.
Yes, sorry, I was finding my way on Zoom. Thank you very much for the invitation and also for introducing me, and good evening, everybody from London. So we're going to discuss now, we're going to focus on how to recognize and how the neuro exam is performed in animals with peripheral nerve system disease. So and have a slight technical. Okay, I think it works like that. So what we're going to discuss, we're going to start quite easy. We're going to talk about what do we mean with the peripheral nervous system, how to recognize animals with disorders of the peripheral nervous system. And I think what is quite interesting is that they present quite a variety of clinical signs, going from quite mild to really dramatic clinical cases. And also important, the examination findings on the neuro exam and how to differentiate them from especially spinal problems, because I see in practice that it seems to be very challenging for veterinary clinicians to differentiate animals with spinal disease and neuromuscular disease. And then we're going to discuss a little bit how to assess these cases, and that's a combination of diagnostic tests and clinical reasoning. We'll do that with a few clinical cases. So what is the central nerve? So what is the anatomy? So all of you know that the central nervous system is the brain, the spinal cord, and then the peripheral nervous system connects the central nervous system with the periphery, the end organ, typically a muscle. What is maybe important is when we talk about neuromuscular disease, it actually has three components. So if you see that this is the spinal cord, from the spinal cord exits the peripheral nerve, and then you have the muscle, and then the third component is the junction between the muscle and the peripheral nerve, which is the synapse. So for this lecture, we're going to focus on only one component of the neuromuscular system, which is the peripheral nerve. And we know that when a disease affects the peripheral nervous system, we call that neuropathy. These conditions, they can often are generalized, so they cause abnormalities in all limbs, but sometimes they can be focal. For example, typically a dog, the peripheral nerve tumor, will just have lameness. So the basic anatomy, but it's really basic, is you have the nerve cell body that's really located in the central nervous system, so the brain or the spinal cord. But then the axon can be located in the peripheral nervous system. And then, of course, the axon is surrounded by these Schwann cells that produce myelin. And you might, often when you have peripheral nervous system, it's kind of divided between an axonopathy, when primarily the axon is affected, or a myelinopathy, when primarily the myelin sheath is affected. So when do you see clinical signs? Only when the peripheral nerves are affected that exits the spinal cord at the brachial plexus or the lumbosacral plexus. And for the anatomy, when we talk about the peripheral nervous system, of course, it's easy to understand that very distal, that's a peripheral nerve, but actually peripheral nervous system already starts in the vertebral canal. So when you have the spinal cord, that's the central nervous system, but then the dorsal nerve roots, the ventral nerve roots, the spinal ganglion, and then the peripheral nerve, those are also parts of the peripheral nervous system. So what is typically the distinction? We call the nervous structure that exits or that originate from the spinal cord, spinal ganglion. Those are the dorsal and the ventral nerve roots. Then from the spinal ganglion till it exits the vertebral canal is a spinal nerve, and then it exits as the peripheral nerve. And it's typically that, for example, in the pelvic limb, it's multiple peripheral nerves that then can contribute to a bigger named nerve, such as a sciatic nerve. What is quite interesting, but I'm not going too deep in it because it's maybe not a discussion, that you know that the spinal cord ends in most talks around L6, L7, and then continues as the cara equina. And in many aspects, cara equina can also be considered part of the peripheral nervous system, also in clinical science, of course, also in pathology and recovery. Also important, and something that confuses clinicians quite often, is that the cranial nerves, with the exception of cranial nerve 2, also part of the peripheral nervous system. So cranial nerve 2 is an extension of the brain, so that's part of the central nervous system. But all the other cranial nerves are parts of the peripheral nervous system. And that's why it's definitely possible when you see an animal with, for example, tetraparesis caused by peripheral nervous system disease, that it will also have cranial nerve abnormalities. So the clinical presentation, we're going to divide it into the clinical signs and then neurological examination findings. So what are the clinical signs? The hallmark is weakness or paresis. And if they can still walk, it's like a very short, stilted gait, a very short gait. But that weakness can have a very variable clinical presentation. It can be just exercise-induced, exercise intolerant. It can go to ambulatory tetraparesis, but probably the most common presentation that we see in the UK is an acute onset tetraplegia. We'll come back to that later. And like I said, you can also have when it's focal lameness, and the big example would be, again, the peripheral nerve sheath tumor. What is important? In severe cases, you can also have respiratory compromise because of paralysis of the intercostal and the diaphragmatic muscle. Ataxia is typically not present. So when you see the animal walking, what I feel is really important, you should ask yourself, is the animal paretic, ataxic, or a combination of both? Because ataxia and paresis, they are not the same. And in animals with peripheral nerve system disease, the animal will be paretic, but not ataxic. And like I said, you can also have abnormalities of the head and face. And very rarely, because maybe some of you are really already advanced in neurology and you want to highlight to me that this is not the whole story, you can have very unusual clinical presentations when the sensory nerve is involved. So like I said, the cranial nerves can also be involved. And what is the big one here is like the laryngeal nerve, vagal nerve, which you can have then laryngeal paralysis, but especially megaesophagus. And that is in animals with neuromuscular disease, the big factor that decides the prognosis, decides the complications. Because of course, when you have a megaesophagus, it's not a question if, but when will the animal develop aspiration pneumonia. And like I said, in some cranial nerve disorders, for example, botulism is a really good example. It's very common to see tetraplegia in combination with multiple cranial nerve deficits. Sometimes you see abnormalities like a change in bark. And that's important because, like I said, it's often challenging for clinicians to differentiate between spinal disease and peripheral nerve disease. And then maybe a change in bark or loss of bark can be very important in the clinical history. So like I said, the paresis can vary. So we'll see, yeah. So it can go from ambulatory, and you see the dog doesn't have ataxia, but when he walks, you will see that it has a very short and stiff limb in all 4 limbs. So you see, is the dog coordinated? He's perfectly coordinated. So it doesn't show ataxia. Is he weak? Yes, he's weak because he has his short, still limb. So this is a typical gait for an animal with a generalized peripheral nerve system disease. It can be more severe, something like this. So this dog is very close to being tetraplegic, and you see can't even support his head. And also what you typically will see in neuromuscular disease is this loss of muscle tone, this decreased muscle tone. Come back to that later. So in severe cases, like in animals that have become tetraplegic, we are always quite concerned about respiratory compromise because, like I said, it's often generalized. And then you can get also respiratory paralysis because of paralysis of the intercostal muscles and the diaphragm. And what you get is very abdominal breathing with minimal movements of the thorax. So this is something that we regularly see in animals that present with acute onset tetraplegia because of neuromuscular disease. So maybe something in cats, because as you know, cats are not small dogs, and there are some misconceptions about cats. And I think 2 postures that you might be familiar with is the plantigrade stance and also the cervical ventroflexion. Now, those two postures cause some confusion because for some clinicians, from the moment they see plantigrade stance in the cats, it's almost pathognomonic for diabetes mellitus or diabetes polyneuropathy. That's absolutely not true. So a plantigrade stance is just a sign of weakness. So they can consider a peripheral neuropathy, and it can be in your differentials diabetes neuropathy, but also we see this in cats with lumbosacral disease. But what is important, this posture is not even pathognomonic or highly suggestive for neurological disease, because it can also occur in orthopedic disorders such as avulsion of the gastrocnemius muscle, rupture of the calcaneal tendon, or fracture of the calcaneus. So, for example, this cat had a bilateral partial rupture of the common calcaneal tendon. So this cat did not even have a neurological problem. It definitely did not have diabetes polyneuropathy. You see that the withdrawal reflex is actually quite good. So sometimes what we see occasionally in cats is not only a plantigrade stance, but also a palmigrade stance. If you look at the thoracic limbs of this cat, this is often referred to the neurology service where I work, but this can actually not be explained by neurological disorder or a neurological localization. So quite often we ask advice from our orthopedic colleagues, and the top differential would be laxicity of or traumatic damage to the carpal ligaments. Then cervical ventroflexion. As you see, this cat can't lift its head. Is a very typical clinical presentation. Again, this is historically often associated with hypokalemia, but also this cervical ventroflexion is just a sign of weakness. You can also see it in non-neurological conditions. So a cat that's just very weak can have this cervical ventroflexion, and dogs have a ligament that runs from the first thoracic vertebra to the skull. It's the ligament, the nugal ligament, while cats don't have it, so they don't have that extra support for the neck. But again, this is not pathognomonic for hypokalemia, and this is even something that we can see in non-neurological conditions. So we go from the clinical signs to the neurological examination, and often finds that peripheral nerve disorders are probably the most difficult to recognize for veterinary clinicians, but often the neuro exam is very specific. So if the animal is strong enough, proprioceptive deficits will not be present. If the animal can still walk, like the dog in the video, proprioception will be intact. But what is really the three hallmarks of peripheral nerve disease is decreased muscle tone, decreased spinal reflexes, especially in animals with a neuropathy. And this is often referred to as lower motor neuron tetraparesis or flaccid tetraparesis. But this is very important. It's a decreased muscle tone and decreased spinal reflexes. And then because it's decreased muscle tone, the animal becomes quite floppy because it's lost all its muscle strength. And that's why we sometimes refer this as a flaccid tetraparesis or tetraplegia. What you can see, but it's often, I think, given too much importance, is severe and rapid muscle atrophy. It's not something that we see often. I see it more with more chronic conditions, and especially if it's lateralized, that you see one side of the body having more severe muscle atrophy. And like I said, you can have decreased cranial nerve deficits, what we discussed briefly. One of the most challenging conditions to recognize is a lameness caused by a peripheral neuropathy, because quite often the neuro exam is completely normal. Like when I go to the dog with the peripheral nerve tumor, for the first weeks, it's almost impossible with the neuro exam to differentiate between an orthopedic or a neurogenic lameness. So like I said, so this is a dog with so you see again the short strided gait in the thoracic limbs, then the short strided gait in the pelvic limbs. Ataxia is not present. So this is the typical gait of an animal with peripheral nerve disease. So an ambulatory tetraparesis without ataxia and a short, stiff gait in all limbs. Now you see this dog has severe difficulties walking, but then when you test proprioception, it's completely intact. And that's very typical for neuromuscular disease, and that's maybe how you can differentiate already between spinal and neuromuscular disease, is that proprioception should be intact. And even when we go back to this dog who was almost tetraplegic, so this dog is too weak to correct paw placement, but you will see that when my colleague starts to do hopping, that actually his proprioception was not too bad. So this is quite a more severe case with tetraplegia or almost tetraplegia. And now my colleague is going to test hopping. But you see it's very challenging because this is very flaccid edge, but you see that the hopping is still intact because when the dog is strong enough. So this is typical for neuromuscular disease. Despite that the dog is almost tetraplegic, he still has intact proprioception. If they have absent proprioception, it's typically because they're just too weak. They lost all motor function in the limbs. So that's why you see, for example, in the pelvic limbs, that the dog is too weak. And also this video shows really well this flaccid nature of the paralysis with decreased muscle tone in all limbs. So of course, because this lecture is a little bit about neurolocalization, so we have to mention some of the spinal reflexes. Now, I'm quite famous for being a very lazy neurologist. I only test 2 spinal reflexes. So I only do the patella reflex and the withdrawal reflex. If you do more reflexes, that's completely fine, but I only test the patella reflex and the withdrawal reflex. What is interesting for the pelvic limb is that with assessing spinal reflexes, you can often localize the problem to one of those specific big nerves. So the patella reflex, so it can be still spinal cord segments, but that's all femoral nerve. The withdrawal reflex is largely the sciatic nerve, but also femoral nerve. So what is very important, I often find that the withdrawal reflex is one of the most challenging reflexes for interpretation, because you not only have to see if the animal withdraws its limb, but you have to check all the joints that are involved. So it should flex kind of the digits, the hook, the stifle, and the hip. And why is that important? Because the femoral nerve mediates hip flexion, while the more distal joints are mediated by the sciatic nerve. So it's very important when you evaluate the withdrawal reflex that you check that all the joints are participating, because it's very common for sciatic nerve problems to do something, but everything comes from the hip. So for the thoracic limb, again, I'm very, very lazy. I only do the withdrawal reflex, but others that you can do is the biceps reflex, triceps reflex, extensor carpi radialis. What is a difference with the pelvic limb is that with the thoracic limb, it's not really possible to localize to a very specific. So it's not really possible, for example, to localize to the radial nerve or something else. So when I talk about decreased muscle tone, often when I ask the students, what do you think of the muscle tone? They start palpating the muscles, but that's not what I mean. What I mean with decreased muscle tone is this lack of resistance, movement of flexion and extension of the limb. So it all feels very floppy. And this is also typical for sciatic nerve problems, that especially distal from the hock, you lose a lot of muscle tone. And this illustrates, so this again, lack of muscle tone distal from the hock. But now when we're going to test the withdrawal, you should see everything comes from the hip here, while there's no withdrawal from the hock and the stifle. So this is suggestive for a sciatic nerve problem with intact femoral nerve function. So dogs with a femoral neuropathy, they can present with a very characteristic frog-like gait, and the neuroexam is characterized by decreased patellar reflexes. And the reason why they present with such a characteristic gait is because actually when you have a femoral nerve lesion, you can't really support weight, and you get something like this frog-like gait. So already when you see this dog, it's highly suggestive for a femoral nerve and then an absent patellar reflex. And the most common reason why animals develop like a bilateral femoral neuropathy is trauma. When they, for example, try to jump and with extended limbs, they kind of get stuck behind something. So probably the clinical presentation that we see most is this flaccid tetraparesis or tetraplegia with decreased spinal reflexes in all limbs. And this is what we say. So this dog is tetraplegic, see, no muscle tone, no patellar reflex, no withdrawal. So you see he feels it, but then when we go to the thoracic limbs, also no withdrawal. So this is the most characteristic clinical presentation of a dog with acute neuromuscular disease or an acute polyneuropathy. So tetraplegia or tetraparesis with absent spinal reflexes in all limbs. And this is something that confuses some people. Like I said, you can see quite dramatic muscle atrophy. In my opinion, it's probably something that we see more it doesn't occur super quick. So often it needs a few weeks to be so obvious. So the question is how to differentiate peripheral nerve disease from spinal, especially spinal disease, but also brainstem disease, because tetraparesis, very rarely tetraplegia can also be seen in animals with cervical or brainstem disease. And then, of course, tetraparesis with cranial nerve deficits can also occur in brainstem disease. And I think this is a very important part of the lecture because I see every year animals with peripheral nerve disease that are worked up with quite expensive diagnostics like MRI for spinal disease somewhere else. And then when the clients come to us, they don't have any more funds to work up or to treat the underlying neuromuscular disease. Because here there's really a danger that if you don't localize correctly to the neuromuscular system of or peripheral nerve disease, is that you will not recognize the most likely differentials and you will not choose the correct diagnostic steps and you will not be able to initiate treatment and prognosis. And what I always find with neuromuscular disease, localizing is the key to success. From the moment you have localized to neuromuscular disease, it's half of the work. So in general, when you see an animal that is tetraplegic, so completely paralyzed on all four, neuromuscular disease or polyneuropathy is the most likely condition. It's very uncommon for cervical spinal disease and especially for brainstem disease to present with complete tetraplegia. With cervical disease, proprioceptive deficits are most often present. Attacks when they walk, and that's why I make such a point that ataxia and paresis is not the same, because with spinal disease, you typically get this combination of paresis with ataxia. So the quality of the gait is quite different. But this is the hallmark. In cervical spinal disease, you will not have decreased muscle tone in all limbs. In cervical spinal disease, you will not have decreased spinal reflexes in all limbs. And it's all very similar for animals with brainstem disease. And like I said, tetraplegia is very uncommon in animals with brainstem and cervical spinal disease because the nerve tracts that go through the spinal cord, that go to the diaphragm and the intercostal muscles, they of course go through the cervical spinal cord. So if you have a lesion that's severe enough to cause tetraplegia in the cervical spinal cord, it will most likely also affect those respiratory muscles. So then typically you will get something again like this. So tetraplegia caused by cervical spinal disease is often associated with respiratory compromise. So when you see a tetraplegic animal, you should always suspect initially neuromuscular disease. So the hallmarks, tetraparesis without ataxia, and tetraplegia is definitely possible. Decreased spinal reflexes in all limbs, and decreased muscle tone, this flaccid character in all limbs. And this is something that confuses still a lot of people. So when we give to our students like a case, like tetraplegia, absent spinal reflexes in all limbs, they always come up with very complicated neuroanatomic localizations. But you know that when we test the spinal reflexes, what you actually test is this nerve, the focal spinal cord segment, and the nerve that comes back. So when you, for example, have an absent patellar reflex, the lesion can be localized or in the peripheral nervous system or in the focal spinal cord segment. Similar for the withdrawal reflex in the thoracic limb. If it's absent, it can be localized or in a C62 spinal cord segments or in the peripheral nerves. So in neurology, we always try to explain everything by only one lesion. So when you have an animal with decreased spinal reflexes in the thoracic and the pelvic limbs, it's really not likely that it has two separate spinal lesions. It's very likely it has neuromuscular disease. So this is really the classic hallmark, abnormal spinal reflexes in all limbs. So personally, even for me or even for us, we have a big and experienced neurology team. It's not easy always to differentiate from spinal and neuromuscular disease. And the reason is because quite often the clinical signs in animals with a polyneuropathy, they start in the pelvic limbs and then they progress over a few days to involvement of the thoracic limbs. So when you see them initially with only the pelvic limbs affected, it looks like they can have an L4, S3 spinal cord lesion. And my advice is, will be very underwhelming and you'll probably be disappointing. What I often discuss, for example, when I see an emergency like that with residents, is that I say, you know, it's very difficult now to differentiate between peripheral nerve disease or spinal disease, but the diagnostic workup is completely different. So maybe we evaluate again tomorrow morning, and then often when you just give the dog a few more hours, you will see that the next day also the thoracic limbs are involved, or the dog also has decreased spinal reflexes in the thoracic limb. So often it's not advisable to rush in with your diagnostics and treatment, but maybe if you're not confident with the localization, give it some time, monitor the dog, and then evaluate again a little bit later, just because you don't want to do an MRI scan or an MRI scan in an animal with peripheral nerve disease. So like I said, also some unusual clinical presentations. So this is a young, and you see this dog also has a degree of ataxia. He has proprioceptive deficits. So he has a combination of ataxia and paresis, and he has proprioceptive deficits. And then when we do the neuro exam, you see that he has absent proprioception. You also see that he has little wounds. You see the crossing of the legs, so that's suggestive of ataxia. So this is a very unusual and a rare clinical presentation, but just to, maybe you are like already advanced in neurology, just to illustrate to you that the rule of every rule is that for every rule there's an exception. And this dog actually has a sensory neuropathy, which is hereditary in Border Collies. It also occurs in other breeds. So it's a degeneration of the sensory, and in more advanced cases, also motor nerve cells. Typically young puppies, 2 to 7 months old, but they typically lack pain, and that's also why they have ataxia, because they don't really feel where they are placing their feet. It also comes with automutilation. It has also been reported in other breeds. So there is a genetic test commercially available. So unfortunately, prognosis is quite poor, and these animals are often put to sleep due to poor quality of life or recurrent infections to those distal limbs. So differentials, it is very, so when you see an animal with neuromuscular disease or peripheral nerve disease, what are your differentials? It's a very long list of differentials. It can be idiopathic, infectious, immune-mediated, it can be paraneoplastic syndrome, it can be congenital, like in a little puppy. Sometimes it's quite straightforward, like in this puppy who has this very characteristic stiff pelvic limbs, which we typically see in Neospora. So in this dog, we just tested for Neospora, and it was positive. But what is with neuromuscular, with peripheral nerve disease, and again, in my team, I'm quite famous for not liking animals with peripheral nervous system disease, because it's often very frustrating to reach a definitive diagnosis. And often, despite all your diagnostic tests, you will not identify the underlying condition. So despite that, even animals with the most dramatic clinical presentations, like tetraplegia with respiratory compromise, they can have an excellent prognosis, even if you don't identify the exact underlying conditions. And of course, the big thing to monitor is respiratory compromise. So how to assess these cases? Clinical history is very important, with especially maybe ask about the bark, because that can be the giveaway to differentiate with spinal disease. And some neuromuscular disorders and peripheral nerve disorders are associated with toxins, and I don't know if it's not legal anymore in every country, like organophosphate esters, but it's now known that the most common neuromuscular condition that we see has been associated with eating of raw meat or chicken. And then the general physical examination, thoracic auscultation and respiratory monitoring is super important. And then, like I said, the neuro exam, finding the neuroanatomic localization is the key to success, and will especially avoid that you do unnecessary and expensive diagnostics. So our work, we really believe in this concept of clinical reasoning. And often when we have visitors visiting our service, they're quite surprised that how little further investigations we actually do. So we should step away from this concept that, oh, you see an animal with neurological disease, so it needs then this diagnostic. So it's the same with neuromuscular disease. We should step away from this concept that, oh, you see an animal with neuromuscular disease, so now you should do blood work, urinalysis, electrodiagnostics, nerve biopsies, muscle biopsies. It's not the diagnostics you do are dependent on your most likely differential diagnosis. And that's something that we strongly believe in. We're going to discuss a few cases. So what we believe is that you use the clinical information to recognize the most likely differential diagnosis. And of course, the signalment can be important. Clinical presentation, like when you see an animal with chronic progressive disease or acute rapidly progressive disease, very different differentials. And we typically, we first say, oh, this is the most likely differential, and only then we consider further diagnostics. And what I feel is that characterizing the clinical presentation is probably the most important step in recognizing the most likely differential. And for example, in peripheral nerve disease, if an animal presents with exercise-induced weakness, or combination with laryngeal and sciatic nerve dysfunction, or an acute onset rapidly progressive flaccid tetraplegia, it's all associated with very different clinical presentations. And we see that, for example, when you see something like that, an animal with laryngeal and sciatic nerve dysfunction, or an animal with an acute onset rapidly progressive tetraplegia, it's actually, when you think about it, there will only be a few differentials that can cause this. We'll come back to that in a second. So this is a Leonberger, and I don't know, so I hope the sound works where you are, because yeah.
Go.
You hear that the dog has inspiratory stress, has laryngeal paralysis, and he also has this typical kind of rooster type.
You can come back.
Gait, which is combination of laryngeal paralysis and sciatic neuropathy.
Again.
And the
Good.
point I want
Thank
to
you very
make,
much.
like this dog has inherited polyneuropathy, is by characterizing clinical presentation and saying, oh, the dog has laryngeal paralysis and a sciatic neuropathy, your differentials become very short. Because this Leonberger polyneuropathy is what we sometimes refer to as a dying back neuropathy, or an distal axonopathy. So fine here, probably, this is a little. So when we said the nerve cell body is in the central nervous system, and then the axon goes to the muscle, it's the peripheral nervous system. So what happens is that all the nutrients and all the metabolism actually happens in the nerve cell body, and then everything gets transported to the periphery, to the distal tip. That's anterograde transport, but also all the metabolites, all the toxic byproducts, then they get transported back to the nerve cell body to get kind of metabolized even further. So what happens in dying back or distal axonopathy is, if, for example, metabolism doesn't work, or there's an error in metabolism, is that the nutrients cannot reach the most distal tip of the axon, or if there's a toxic problem, is that the nutrients cannot go back, or the toxic byproducts cannot go back to the nerve cell body. So what you typically see for this type of conditions that are associated with a metabolic error is that the most distal tip of the axon is most vulnerable, and the degeneration will start from the most distal tip of the longest peripheral nerves. And the longest peripheral nerves are the sciatic nerve and the laryngeal nerve. And it's very well known in horses, this combination with laryngeal and sciatic neuropathy. So, and of course, this is maybe a little bit more kind of advanced neurology, kind of the dying back, but this just shows that if you recognize the clinical presentation, you can immediately say, oh, this is a dying back or distal axonopathy. And quite often these are inherited conditions. So for example, in this dog, it's a bit of a complex disorder because it's quite a wide age range. It's progressive and poor prognosis. Some suggest that maybe younger dogs have a more severe phenotype and a more rapid progression. There's also been suggested that there's like an X-linked inheritance, but maybe the reason why it's a little bit heterogeneous because there are different mutations that can cause this similar clinical phenotype in Leonbergers. Also in St. Bernard's, you have a similar syndrome, but for example, in this dog, there are genetic tests. So this would be a dog where we say, you know what, it's a Leonberger, clinical signs are suggestive for this dying back neuropathy. So we just do a genetic test, and we don't do any further diagnostics than that. Of course, if we feel the dog might have aspiration pneumonia, and of course, then we do thoracic radiographs. But what is also important with this combination of laryngeal paralysis and sciatic neuropathy is that often the laryngeal paralysis is the first indication of a polyneuropathy. So especially if a young dog presents to you with a laryngeal paralysis, before you go to surgery, for kind of tying back surgery, it should be discussed with the owner that maybe it's a component of a more generalized neuromuscular or neuropathy. So what are diagnostic steps? What I feel is most important is full blood work and thoracic radiographs. So we said neuropathies can be secondary to a whole lot of conditions like metabolic conditions, inflammatory disorders. Sometimes these dogs also not eaten or dehydrated. So full bloods, especially in conditions that are associated with rapid muscle atrophy, creatine kinase is quite important. Electrolyte disorders are very important. Thoracic radiographs would always recommend. It doesn't occur in every polyneuropathy, but there's always a risk that there's a megaesophagus, and you want to diagnose it before the animal has an aspiration pneumonia. And some peripheral neuropathies are kind of paraneoplastic. So when you do thoracic radiographs, maybe you can see in the thorax if there's something abnormal. Urinalysis. But we sometimes discuss with our owners, we can do abdominal thoracic imaging to see if there's anywhere an underlying condition that can be associated with this neuropathy. So like I said, thoracic radiographs can be very important to evaluate for megaesophagus, and as you see here, aspiration pneumonia, because that's the big game changer when we talk about prognosis. And then, of course, there are more specific tests. The Tensilon test, the hydrophonium chloride, is something very specific when you have a high clinical suspicion of myasthenia gravis, which is not a peripheral nerve disorder, so it's a junctionopathy. But some of the specific tests are electrodiagnostics, like electromyography, motor and sensory nerve conductions, repetitive nerve stimulation, and muscle and nerve biopsies. Of course, there's only a few labs in the world that have experience in evaluating muscle nerve biopsies. So often handling, storage, and transport is quite challenging, because often when it's harvested, it almost has to be transported immediately under very specific circumstances. So electrodiagnostics, muscle and nerve biopsy. Again, I'm a little bit well known in my team for not being a big fan of these diagnostic steps. Some of my colleagues really like it, and if you like it, that's completely fine. I will not judge you. So what are, in my opinion, the advantages of doing these advanced diagnostic steps? They can confirm that the animal has a neuromuscular condition. It can differentiate, give you information if the animal has a neuropathy, a myopathy, or junctionopathy. If it's a neuropathy, it can probably tell you if it's most likely an axonopathy or myelopathy, and maybe it can provide some prognostic information, but that's not that well known. But what I think is the limitation of these diagnostic steps, abnormal electrodiagnostics or even muscle nerve biopsies, it's very common that they don't confirm the exact diagnosis. And when we and also it requires general anesthesia. And for example, if these dogs have already an aspiration pneumonia, it's quite time consuming. Like a good electrodiagnostic evaluation takes at least an hour, so it's not a quick diagnostic method. Of course, it increases expenses. And what is with muscle biopsies? Like I said, only a few labs in the world can do this. It often takes quite a while before you have results back. So For us, it's not uncommon that when you take a muscle or nerve biopsy, only 2 weeks later, we have an answer. And in those 2 weeks, maybe the animal has recovered already, maybe the animal has died. Sometimes the owner is full of expectation from the muscle and nerve biopsy. And then if we have to come back to them and say, come with a very non-specific diagnosis, it's often quite disappointing. So one case for you. So it's Snuffle, a 10-year-old male neutered Jack Russell. It was completely normal 2 days ago. And then yesterday had difficulty supporting his weight on the pelvic limbs. And then today also thoracic limbs. And it's a very classic presentation of first the pelvic limbs and then the thoracic limbs are involved. So it's now progressed. He's more or less tetraplegic and he tries to bark, but the pitch has changed. So this is Snuffle. And he came with a urinary catheter from the referring vet because they thought he had a spinal problem. But you see also has difficulty supporting his head. So he still has some movement in the thoracic limbs, but you see a short, stilted gait. And again, this decreased muscle tone. You see intact proprioception, very typical for peripheral neuropathies. But you see, this is also something that we often see in animals with peripheral neuropathies, is that actually they even have difficulties supporting their head. Intact hopping. So like I said, in peripheral neuropathies, animals typically, if they still have enough strength, they have intact proprioception. Looks quite sad. Then the hallmark is, of course, muscle tone and spinal reflexes. So you see decreased patellar reflex. And then he doesn't like it at all, but no withdrawal reflex. So it's intact pain perception, but no withdrawal reflex. And then when we go to the thoracic, again, you see that decreased muscle tone. It's far too easy to flex and extend, but also no withdrawal. So this can only be caused by peripheral neuropathy, by polyneuropathy. Now, the question is always what I ask is like summarize a neuro exam. What is a neuroanatomic diagnosis? But very important is what is the most important differentials? What is the most likely differential diagnosis and the prognosis associated with it, and how would you treat Snuffle? So a rapid progressive acute onset tetraplegia. So I think what was quite important is that he had this intact power placement, decreased spinal reflexes in all limbs. So we can indeed say the clinical presentation is suggestive for neuromuscular disease. Because he's tetraplegic with absent spinal reflexes, it's very suggestive for polyneuropathy. This clinical presentation is what we refer to as this flaccid tetraplegia. Dog just has no strength, no muscle tone. Cranial nerves can also be involved. Often the facial nerves, if you do the Menes response, they don't do it. Megaesophagus can occur, or dysphonia and aphonia. So, and this is a bit of clinical reasoning. So, and that's why I said correctly describing the clinical presentation is key, because you say the dog is tetraparetic without ataxic neuromuscular disease, but it has decreased muscle tone and decreased spinal reflex. So we can kind of define it a little bit better to a neuropathy. All the limbs are affected, so it's a polyneuropathy, but what was the onset and the progression? It's an acute onset, rapid, progressive polyneuropathy. And if you remember the Leonberger, the lemur had for me a very different clinical presentation than this talk. And that's what I mean, like by recognizing the clinical presentation, you can formulate your most likely differential diagnosis. So what are the top differentials? And actually, for this clinical presentation, there are only a few selected differential diagnoses. Only a few conditions will cause this. So the top differential always is a condition that we call acute idiopathic polyradicular neuritis. In the States, they sometimes call that Kuhnhand paralysis. In the very acute stage, they can have some spinal pain. We'll discuss in a second why. And if they have cranial nerve deficits, it's typically facial nerve paresis. Then a condition that occurs far less common, it's botulism. Clinically, there can be different because they have multiple cranial nerve deficits, and it can also have involvement of the autonomous nervous system, such as incontinence, diarrhea, things like that. Typically in the clinical history, there can be something of scavenging or eating rotten meat, something like that. And I don't know if some of you work in North America or Australia, that tick paralysis is a very important differential. In the UK, we don't see that. But so tick paralysis is very important. So actually, for this clinical presentation, there are only 3 likely differentials. So when you recognize the clinical presentation, you characterize it, you only have to differentiate between those 3 conditions. So acute idiopathic polyradicular neuritis, it's by far hands-on the most common cause of acute, rapid, progressive, flaccid tetraparesia or tetraplegia. I would really say from the moment you see an acutely tetraplegic dog, this should be your top differential. It has been compared to the Guillain-Barré syndrome in people. The exact pathophysiology is unknown, but maybe there's some molecular mimicry, there's some involvement of the immune system. Predisposing factors, there's some breeds like the Jack Russell, like Snuffle, or West Highland White Terriers. In UK, we see maybe more cases in autumn and winter. And this is quite interesting. It's a newer paper from Australia. They apparently feed a lot of raw chicken to their animals, and they see that there's an association between feeding or exposure of raw chicken and development of acute polyradicular neuritis. And if you're interested, that's the paper. Also, JVM, it's open access, so if you want to read it, you can just access it for free. But they say that acute polyneuropathy cases were 9.4 times more likely to be positive for Campylobacter compared to control dogs. And of course, Campylobacter is associated with raw chicken. So what happens in polyradiculoneuropathy? A very specific structure. Here, the ventral nerve root gets affected. And in the acute, because the ventral nerve root is so closely associated with the spinal cord, that in the acute stage, when you do spinal palpation, you can find some spinal pain. So that complicates, again, that differentiation with between spinal and neuromuscular disease. But also because that ventral nerve root is still included in the subarachnoid space, in the meninges. So even when you do spinal tap, you can get increased protein for these cases. This condition is never associated with a megaesophagus, but respiratory compromise can occur. It is even relatively common because of paralysis in tetraplegic animals of the intercostal and diaphragmatic muscles. When you get cranial nerve, it's typically the facial nerve, like in this dog. And you see it's already receiving oxygen. And this is also a reason why I make such a point of not doing unnecessary diagnostics. Because if this dog deteriorates, it's possible we will discuss with the owner mechanical ventilation, which is very expensive. But then it would be really sad if the owners have spent multiple £1,000 on an unnecessary MRI scan and cannot invest that money anymore in mechanical ventilation. So the prognosis is dependent on the progression and the severity of the clinical stage in the acute state, but in general, prognosis is excellent. So especially if no respiratory compromise occurs, but this is one of the top conditions where even if animals have to go on a ventilator, they still have a really good prognosis. So supportive care, physiotherapy, hydrotherapy, some dogs recover after a few days, some after a few weeks, and even had some dogs that need 1 or 2 months to show improvement. Despite that this is probably an immune-mediated condition, there's absolutely no positive response with steroids. Even the opposite, because a side effect of steroids is muscle weakness, is that it even might aggravate the clinical signs. There is a debate in human medicine. This is treated with plasma transferase or immunoglobulins. It's sometimes used in veterinary medicine. Also, we sometimes use this. Is there evidence? There's some evidence, but not really conclusive evidence. So this is a paper that evaluated the use of immunoglobulin for animals with acute polyneuropathy. And when you look at the difference, it's quite big difference, but it was not significantly different. The problem also with this type of treatment is that we typically use it in more severe cases, while in milder cases, we just do physiotherapy and hydrotherapy. So how does it progress? So typically in acute stage, they rapidly deteriorate. They become paraplegic, then tetraplegic, they can develop respiratory compromise. Then they stay like that for a while, can be days to weeks, and then they start to slowly improve. So it really depends where this point is, how easy they will be to manage. Because if they are here and they are not completely paralyzed and they have no respiratory compromise, it will be relatively easy to manage and prognosis is excellent. While if you're tetraplegic with respiratory compromise, it becomes more challenging. So this was Snuffle. So treatment was physiotherapy, hydrotherapy. And like I said, so they can have respiratory compromise. You see here again, the thorax is not moving too much and everything comes from the abdomen. So this is, for a lot of clinicians, your worst nightmare. You know, it's Friday afternoon, you have a tetraplegic animal with respiratory compromise. So what is the prognosis? Prognosis is actually really good, because this was the dog a week later. We didn't do advanced diagnostics. We didn't do expensive treatment. And of course, it's still ambulatory tetrapyretic, but the dog looks really much better. And we expect him to improve even more. So that's why I say that obtaining the neuroanatomic localization is the key to success. Because if you recognize that this dog has a neuromuscular disease, and more specifically a polyneuropathy, and you characterize it as an acute onset, rapid progressive tetraplegia, you know there are only a few differentials, and you know that each of those differentials actually, despite the severity of clinical signs, has quite a good prognosis. So the take-home message for Snuffle is that making accurate neuroanatomic localization was key. And again, despite excellent prognosis, despite dramatic clinical signs, and it's often something that we see often in neurology, is that the most peracute, severe clinical presentations often have really good prognosis and they improve often by themselves. So the last slide, hopefully it was not too long for you. So for conclusions, obtaining a neuroanatomic localization can be challenging, but the key is paresis with ataxia, decreased muscle tone, and decreased spinal reflexes in all limbs. And if the animal still has enough strength, then proprioception should be intact. And you can also have decreased cranial nerve reflexes. So for example, when you have a tetraplegic animal and suddenly it also has cranial nerve deficits, that's no reason for concern. It can still be just neuromuscular. Cool. So I don't know if there are any questions.
Great. Thank you very much for that lecture. It was amazing. We have a few questions. The first one is from Christian, who is asking about why most of the peripheral nervous system disease start with things in the pelvic limbs.
It's a really good question, and nobody knows. So it's something that I've seen a few cases where it started in the thoracic limbs, but I think nobody knows why it starts in the pelvic limbs and typically progresses to the thoracic limbs. So no answer there, unfortunately.
Okay. Another doctor asked about the diagnostic procedures. You spoke a little bit of this about general diagnostic approach, but maybe in cases like snuffle, what is your diagnostic approach in that cases? You make some test or just?
It's a very good question, and like I said, I'm a lazy neurologist, often do minimal diagnostics. So what I typically do is blood work to see if there's no underlying condition, maybe urine analysis. If the owner is motivated to see if there's any underlying abdominal or thoracic abnormalities, I do whole body CT. And for me, it often stops there.
And why the full body CT?
To see if there are any underlying conditions like
Okay.
Like an abdominal neoplasia or abdominal infection. If they don't want CT, then just a thoracic radiograph. So often it's blood work, urinalysis, and a thoracic radiograph. Sometimes instead of a thoracic radiograph, a full body CT. But I question, and I'm very happy for somebody else to have a different opinion. So it's not that or even some of my colleagues disagree with me, and that's completely fine. I question if in a case like snuffle, where you only have 3 differentials, and all 3 differentials are treated the same and have the same prognosis.
Okay.
If electrodiagnostics are going to provide you with enough answers to make it worthwhile. So quite often, but I don't want to discourage you to do electrodiagnostics. Quite often I don't perform electrodiagnostics or muscle or nerve biopsies in these cases. So it's typically we recognize the clinical presentation and we discuss directly with the owners the most likely differentials, treatment, prognosis. And also what I find is if these dogs have to go on the ventilator, they still have a really good prognosis, but it's very expensive. Like with us, it's £1,500 extra per day on the ventilator. And then if we can then save money by, for example, not doing electrodiagnostics, then often they can still afford it.
And in your experience, it's just a few days of ventilation, right?
Often 2 days, maybe 3 days. So that's why I say often when dogs go on the ventilator, it's for whatever reason, already it's kind of end of the story. But this is one of the conditions where actually they have a really good prognosis. So what you actually do is that you just buy time for the dog. So because you expect spontaneous improvement after a few days, so you just take away that effort of the dog to try to breathe. And typically it's 2-3 days on the ventilator.
Okay. I see a lot of people in these cases searching for infectious disease like Toxoplasma or Neospora. You think that is really uncommon in this presentation, right?
Yes. Yeah. So Neospora in puppies, it gives typically those rigid, stiff limbs. Neospora in adult dogs typically give cerebellar disease, not necessarily.
Yes.
But what the big concern is for Toxoplasma is overdiagnosis. So Toxoplasma, we don't, it's for example, in cats, it's every textbook will say, oh, Toxoplasma is almost associated with feline neurology, but it's such an uncommon condition while the seroprevalence is so high. And that's why actually when you look at the diagnostic criteria for Toxoplasma, it is a compatible clinical science, laboratory evidence, and then what is very important, exclusion of all other conditions and a positive response to clindamycin. So typically, even when it is positive for Toxoplasma, it's still more likely it has another condition. But I think Neospora is just quite uncommon. But of course, where I live, maybe where some of the participants live, it's more common. But Toxoplasma, there's a really, really realistic risk of overdiagnosis, false positive diagnosis, and then starting wrong treatment.
Okay, thank you. There's another question from Juan Pablo who says, have you ever seen a case of a dog with masticatory muscle atrophy, dropped jaw, and megaesophagus in the same time?
Yes. I have seen a lot of combinations of cranial nerve deficits, and I think I might have seen dogs with megaesophagus and a drop jaw and muscular muscle atrophy. But quite often it's a bit challenging to reach a definitive diagnosis there. But that might be a case for us because you have a combination of multiple cranial nerve deficits without peripheral nerve, without kind of tetraparesis, where we might probably consider MRI to look for brainstem lesion.
Okay. There's another question about, I think it's talking about a case like snaffle, but in a cat.
No.
What's your differential diagnostic then?
No, it's a very good question because cats are always very different than dogs. And most of the conditions that we see in dogs do not occur in cats. So when we see kind of an acute onset, rapid progressive polyneuropathy in cats, two conditions are quite common, especially some purebreds. We have the demyelating, remyelating neuropathy. It's what we typically see in Bengals, but also we actually see much more common. It's more recently described. It's kind of an presumably immune-mediated polyneuropathy in young cats. And I think especially British Shorthairs might be a little bit predisposed. And treatment there is a little bit controversial because it's unclear now if you should not treat, just supportive treatment in cats will improve by themselves, or if treatment like steroids will have any benefit. And when I say it's unclear, also when you look at the papers, there is no conclusion. But in cats, we see more in young cats. Yeah.
Okay. Of all the diseases that you make in the differential diagnosis, in maybe case like snaffle, what is the worst of those?
The worst of the three conditions?
Yeah.
Probably they're all the same. So the tick paralysis, if you find the tick, you remove it, then typically they start to improve. Although I heard that in Australia, the Australian ticks, maybe the clinical signs are not always reversible. I might be wrong because I've never seen a case with tick paralysis. But for example, botulism and an acute polyradiculoneuropathy, they have a pretty similar prognosis.
Okay. I think the worst maybe if we extend a little bit, maybe myasthenia gravis in a fulminant.
It is, but I did not discuss it because I've seen it twice in my life, and the dog, and twice. So one, it's not very common, and twice the dog just died in the consult room because the foam is already, they present already with like severe aspiration pneumonia, the foam is coming out of their mouths. So what I have difficulty to believe is that when you see a tetraplegic dog without any respiratory compromise, that fulminant myasthenia gravis is an important differential.
Okay. There's another question who asked about neostigmine in megaesophagus.
Yeah.
If you have some experience.
No, yeah. So I think the question maybe is if we see that megaesophagus is reversible with neostigmine.
Yeah, maybe, yeah.
Because of course, the dog has to have myasthenia gravis, so we should not try it if the dog doesn't have myasthenia gravis. It's not always reversible. So myasthenia gravis is actually a very frustrating disease, because what we often see with treatment is that the gait abnormalities and the strength becomes better, is improved, but that the megaesophagus is not necessarily reversible. And often it takes until the dog goes into spontaneous remission before the megaesophagus restores again. But it's not uncommon for the whole duration of treatment for the megaesophagus to be present. And when I treat animals with myasthenia gravis, they often go from one aspiration pneumonia to the other.
Okay. Okay, there is another question. What about the anti-GM2 ganglioside antibodies in the diagnosis of acute canine polyradiculoneuritis?
Yeah, so that's like snuffle, like acute polyradiculoneuritis. It is not something that is performed in practice for clinical reasons. I think there was a very interesting paper also, and I think where it contributed to the to the veterinary literature was more kind of the underlying pathophysiology, but it's not. I've not yet. Maybe something we can consider, but for now, I have not considered it as a diagnostic tool. Maybe I should.
Mm-hmm. And there's the last question, I think, is could a decreased patellar reflex seen more often in older dogs be indicative in lower motor neuron disease?
Which reflex?
The patellar reflex.
Yeah.
A decreased patellar reflex seen more often in older dogs be indicative of lower motor neuron disease.
Yeah, that's a very good comment. So the patellar reflex can indeed be absent under physiological circumstances in two occasions. One is after dogs had stifle surgery or have a stifle problem, then often the patellar reflex remains negative. And the second is in older dogs. But then it should be symmetrical. So if you see an older dog with negative patellar reflexes, but no other gait abnormalities, it's absolutely clinically irrelevant. But
there are a few papers there.
Sorry?
There are a few papers there who talk about this.
Yeah.
Okay. A lot of people say thank you very much. A lot of people. So good. I think that was the last question.
Good.
Okay. Thank you very much, Doc. It's a very nice presentation.
Thank you very much. See you next time. Bye.
See ya. Bye. Bueno, tenemos la próxima conferencia el día 22 de noviembre a las 19 horas hora Colombia, que lo tenemos a Gibran Castillo, que va a estar hablando de la aplicación clínica del electroencefalograma. Ya empezamos con el módulo de electrodiagnóstico. Buenas noches a todos.